How's the coffee machine not working?
All right, perfect. I think somebody might need to go on mute. Welcome everyone back to another Friday morning. So Patient Summary FHIR IG call. This is our second. We had a really good kickoff meeting last week. And so what we'd forecast is to start going through some of the outputs from the AU Patient Summary Clinical Focus Group and take another look at the technical use cases in more detail. So that's what we're going to do. But I'm going to kick off with an acknowledgement of country. And I'd like to acknowledge the traditional custodians of the lands on which we all gather today. And for me, that's the Turrbal and Yagara peoples. And we pay our respects to elders past, present, and emerging, and extend our respects to all Aboriginal and Torres Strait Islander people. And we acknowledge the First Peoples as the first scientists, educators, and healers. And in today's agenda, we're going to do usual business of a technical design group. So that's approval of minutes of the last meeting. And we're also going to go through any actions, updates, and news before we go into the first major item today about the outputs from the AU Patient Summary Clinical Focus Group, and then go into our technical use cases, revisit some of our assumptions, and talk about what's coming up next, because we're going into, after this meeting, which I guess really is the context and the setup for that, the one-day patient workshop, the one-day scoping workshop for Patient Summary in December. So that's our agenda for today. And so the first thing I'm going to do is approval of minutes. So we'll go to those. They've been sent round for review. And so they're up on Confluence now. We do have the list of attendees. There's the recordings and the slides, the outcomes from the mentees that we went through, and a summary of what was discussed and the key points. Now, does anyone need more time to review this before we approve? All right, I'm not hearing anything. So I think at that point, I'd like to entertain a motion to approve the minutes of the last meeting.
It's Kathleen here. I'm happy to move that.
Thank you, Kathleen. Would anyone like to second?
Second that, Josh.
All right, so now I'm going to bring up the electronic poll. Where is the button? There we are. Okay, so this is how we approve the minutes. So you will see popping up on your screen now an electronic poll for approval of the minutes of the previous meeting. So please select affirmative if you're happy with those minutes to be approved. If you didn't attend the meeting, absolutely, you can click abstain. If you're not happy with something or think that some part of the minutes need to be adjusted, please vote negative. So we've had about 70% of people vote on those now. So I'm just going to let that sit for just a couple more seconds. All right. I think we've still just got a couple more people to vote, either affirmative or abstain if you didn't attend the meeting last week or you're not comfortable approving those minutes yet. And now I'll count that down from 5, 4, 3, 2, 1. And I'll end that poll and I'll share the results. So 27 have voted to approve the minutes, 0 negative, and there are 14 who have abstained. So that motion has passed. And I will stop sharing and come back to this now. So out of the minutes of last week, there were no actions captured. And in terms of updates, there's actually quite a lot that's happened in the background, but we've got specific agenda items. So we're not going to cover them here and then repeat them again and again. So what we'll do is we'll leave the updates around the clinical focus group, around AUCDI, around the upcoming workshops to be in those segments of the agenda. If you have any questions as we're going through and presenting, please put your hand up using Zoom reactions. And we'll cover that. If you had a question that hasn't been covered by what someone is going through. Fair warning, today we're going to use Menti as well, so be prepared for that. I wanted to revisit this one briefly, especially for the context of what we're about to look at today, where we're looking at outputs that are both coming from the clinical focus group and also looking at our technical use cases. And that's some of the context really for today, that we're going to be working together over the next 12 to 18 months on the AU Patient Summary FHIR IG project. And that is going to involve a lot of collaboration between outputs and working together with the clinical focus group, with the CDG, as well as this group in looking at more of, I guess, the technical space. And we also want to be able to drive and provide improvements into the international standard space. So one of the things that's key here is that you are familiar with IPS and IPA, the current builds. If you're not familiar with them yet, please go have a look at them and start to get familiar. They're actually open for review now, and a number of Australians provided comments into the last ballot that are being discussed and actioned, and we still have the opportunity to be providing feedback into those as we go through this project. I've also got just the other parts of the checklist up on the right. If you haven't officially registered your interest through the Sparked form, please do so. That gets you on the mailing list, so you'll always get the invites for these meetings and anything we're trying to do around events or updates. If you are implementing Patient Summary, or you already have implemented, or you're going to be working on it soon, you can also complete and provide the AU Patient Summary survey. And that will be fed in, and we'll start to actually look at who is working on what are the data priorities over the next couple of weeks. I also want to call out again chat.fire.org. That's really key for how we're going to be communicating over the next couple of weeks, and where we put announcements and how we're going to get into some more of the technical discussion, both in Australia, but also engaging with the other jurisdictions internationally who are implementing. There's a bunch of conversations going on with Canada at the moment, Brazil as well, and New Zealand. And we really need you to be able to engage fully, to have signed up for HL7 account. That's how you're going to be able to provide more detailed feedback onto what's being shown today, specifics of like the names or the wording of the use cases, and also when we have a draft FHIR implementation guide, how you can provide feedback into that. So just re-emphasizing that from our kickoff meeting last fortnight, that those things are going to be really important to allow you to engage with all the things that we're discussing. So at that point, I'm actually going to hand over to Tor. I think, Tor, I hope you're on the line. I didn't check to go through.
I'm here.
Perfect. All right. You just tell me when to hit next slide.
No worries. So I guess I'll just start with, for those that don't know me, my name is Tor. I've joined the Spark team in an engagement lead role, and I'm helping to facilitate the Patient Summary Clinical Focus Group. Next slide, Danielle. So the purpose of today's update was really to provide this group with an overview of what the clinical focus group has been working on, and mainly running through the consumer journey maps. Also just wanted to give a quick reminder of what the clinical focus group is and does. So basically it's a subgroup of the Sparked CDG. The focus is around developing the clinical scenarios and workflows to support patient summary. It's also looking at the development or supporting the development of the test data and test data requirements for patient summary, to be a resource for this patient summary project, and also to develop any supporting clinical materials if required. So if you do want any information on the patient summary clinical focus group, all of the information is published on the Sparked website, including our minutes, our terms of reference, and any materials that are generated out of that group. I also do want to call out that for the clinical focus group, there are some items that are out of scope. The out of scope items for the clinical focus group is AUCDI R2 development of the data groups and the data elements. So that still remains the remit of the Spark CDG, and all the work around developing the specific data groups and any definitions, etc., is with the CDG. And also, obviously, the technical discussion and the development of the FHIR IG sits with this group, and we're very grateful for that from a clinical perspective. Next slide. So moving on to the consumer journeys today, just to give you an overview of how these were created. So the clinical focus group were presented with the descriptions of the technical use cases and the associated storyboards that were developed for those technical use cases. From there, we then built out the consumer journey maps. So the discussion with the clinical focus group identified that a bit more flexibility was required than what the storyboards provided, which is in order to expand on some of the aspects of the use cases, and hence why we went to these maps. So additionally, we started with the 3 use cases, but in discussion with the clinical focus group, some additional scenarios came up. And so 2 additional consumer journey maps were created. So just want to call out to keep in mind when looking at these journey maps that the CFG really focused on discussing the wider clinical scenarios around patient summary, unbound by system capabilities, with the aim of teasing out questions around the use of the patient summary workflow, the use of patient summary in the workflow, and any policy considerations, infrastructure, etc. So they are quite expanded. So the the consumer journeys that we did create are the interstate GP visit, emergency hospital attendance, referral to a specialist and allied health, a hospital to aged care interstate transfer, preoperative surgical referral workflow. So the first 3 consumer journeys align quite heavily to the technical use cases and the storyboards that were created. And the additional 2 that were created specifically in the focus group are the hospital to aged care interstate transfer and the preoperative surgical consumer journey. So on this call, what we're looking for from you today is to validate with this group, do these consumer journeys make sense for the AU Patient Summary project? Oh, sorry, I can see there's a hand up.
That's from Richard.
The preoperative surgical, would that be
Yes.
what, from a GP to a
Oh,
hospital?
wait, though. Hang on, Richard. They're going to be walked through, so I think
Fine,
your
good.
questions will be
Right.
answered.
Okay, thank you.
Yeah, I will go through them in detail. So yeah, if you're happy to wait until we get to that one, we can touch on that. So sorry, I was just saying, do they make sense as a consumer journey for this project to support patient summary? Does your particular use case or workflow appear in these consumer journeys? Is there a missing consumer journey that's required to support AU Patient Summary R1? Are there any updates or changes that are required to these consumer journeys? And I think also just noting as well that for the consumer journeys that we have created, our intent is that we'll also then create supporting test data that will be built out and then available to use as a part of the test suite at connectathons and test events. Next slide. Thanks, Dania.
So can I just frame for
sorry.
this group that the activity that is about to be gone through is Tor will present all 5 of these. They're here. They will be walked through. And you can pop your hand up during the presentation of those to ask some clarifying questions. And we can get into a little bit of discussion on them. There's also going to be an activity at the end of those 5 to go through the discussion on validation. Does this make sense? Is there anything else we need? And that is, I guess, a set of mentees and things that we've got of the activity after the presentation of those. Is that right, Tor?
Yes, that's right. Yeah.
All right.
And I will just say, as we go through, if you do have questions that come up that I can't answer in the moment, more than happy to take those away and then provide feedback back into this group. So we'll start with the interstate GP visit, and this scenario aligns quite closely with the patient-driven technical use case scenario and storyboard. So in this scenario, our patient is Jeremy Ezra Banks. He's a 73-year-old male. Jeremy is comfortable with technology and uses an app to manage his healthcare records. So Jeremy decides to go on an interstate holiday to Queensland, and prior to travelling, he checks that his patient summary has been updated by his usual GP following a recent hospital admission. So moving on to step 3, feeling unwell, Jeremy books an appointment with the GP while on holiday in Queensland. During the consultation, Jeremy provides access to his updated patient summary. The Queensland GP then retrieves the patient summary from his usual GP. The GP then uses the patient summary during the consultation in order to provide care to Jeremy. Then updates Jeremy's patient summary along with writing back to he then updates Jeremy's patient summary along with writing back to Jeremy's usual GP. So I would like to note on this at this point as well, that during the discussion in the clinical focus group and the development of these journeys, there were quite a number of questions that we did have as the clinical group that were raised when developing these journeys. The questions that came up were around how some of this might work from a technical perspective, what the workflows are that might or might not be followed, what policies or guidelines might be required to enable these types of workflows with patient summary, and other broader questions as well. So the group, in discussing these topics, used the term of hairy questions to refer to some of these things that need to be unpicked. They are something that may come up in your patient summary workshops next week. We don't want to focus on those today necessarily, but I guess I did want to call out that those types of questions had been raised by the clinical focus group for each of these consumer journeys. So I might pause there and just see if there were any questions or feedback or initial thoughts on this first consumer journey map. Richard.
Was there a consensus around the ownership and curation of the patient summary? Because step 5 has it that the usual GP, in a sense, is responsible for the patient summary, and then step 7 has a different party making changes to that patient summary. So there's a lot of interesting stuff around ownership and curation and so on. Is there a sort of a consistent, is there a dominant thread amongst the consultation on how this will work, or is this still really up in the air?
Danielle, can I?
Yeah, please go ahead, Danielle.
The use cases are the context, Richard. So in some I think it's really important to probably not get caught up in that today, but just sort of to answer that question or steer it in the right direction. The reality is that if a GP makes a patient, there may be multiple people who make a patient summary. There is no one patient summary to rule all patient summaries. I just want to be clear. Different patient summaries have different use cases or periods in time where they are going to be created for. So there may be a use case where a patient summary is created and there may be multiple different clinicians who feed into that and update and edit it. There may be a patient summary that's created from a source system where just the one clinician is the one who creates and edits that patient summary. It will be heavily dependent on the specific context of the use case being applied.
Fine,
Yeah.
thank you. It's just when I read 7 makes it look like there is a patient summary. Just the particular wording suggested to me an extremely difficult to construct model.
I think that's a really good point. And Richard, I think there'll be a link at the end, and Tor will provide how you can provide feedback on the exact wording here. And that would be really great if you could come and capture that specific query so that can come back to the clinical focus group to clarify that point. I think that would be a really good way of going forwards.
Yeah, absolutely. Appreciate that. Thanks, Richard. Kathleen?
Yeah, I think I sort of understand it's about the semantics of how the last number 7 dot point is probably written, but my question more is around number 4 is, so Jeremy provides access to his updated patient summary. So are we saying that this summary is only available for access if the patient provides the access, or is it just that they can provide access or the clinician can request access a different way?
So in this scenario, in this consumer journey, we've aligned quite heavily to the first technical use case, which is where the the patient-driven patient summary in which the patient provides a link, as you can see, Danielle, thank you, that identifies the patient summary in the source system. So in this instance, it's where the patient has basically mediated the clinician's access to the patient summary.
I think that's probably a good point. Can we phrase that in terms that each of these scenarios, or these consumer journeys, are designed to illustrate one, I guess, of the technical use cases, though of course in reality this same interstate GP visit could have been chosen to illustrate one of the others.
I think it's a really good thing that Heath framed it as in our last catch up, Danielle, where they to your point, they cross over. Like, there are technical use cases and there may be many use cases that map to that technical use case, just as these are clinical use cases and there may be multiple technical that map to a clinical use case, depending on the context, if that makes sense. So I think there's overlap. And yeah.
I think the use cases are great. What I'm struggling with internally here is the patient summary is written by clinicians and the patient or the clinician can access it. I don't think that's clear prior to looking at these scenarios. I think the scenarios are great and they provide all the technical use cases and what could happen and what may happen. But I think that overlay of what is the patient summary only clinically driven? Yes, the patient might have access to it. And then, yes, they might be able to provide access to another clinician, but also can clinicians access it regardless? Do you know what I mean? It's that
I do,
that higher
Kathleen.
level.
I think we're suggesting almost that there's two flavors of this interstate GP visit. One that is, because I mean, this is, I guess, pretending what happened this time. In this case, Jeremy did it, but we could have the other flavor of interstate GP visit, which is the case in which it wasn't Jeremy, it was actually the clinician who was the one who provided access. I absolutely agree with that.
Yeah.
And I guess we'll pose a question at the end on whether, because that's another way that we can go forwards with understanding these, is to actually ask that not just it's one unique clinical scenario for each use case, but we could pick a scenario and go, well, here's what it actually looks like for each of the different technical use cases, which might drive that point home further. So that's something to contemplate if that is the preferred way we use the clinical journeys in our discussions.
Absolutely. And I think as well, I just wanted to sort of call out when we were discussing these, developing these journeys with the clinical focus group, and even in the CDG face-to-face last week, similar discussions and similar questions were raised, which kind of goes back to what I had mentioned earlier, where we had sort of, in the clinical focus group, identified that there were these hairy questions around each of the consumer journey maps that were created. So thanks, Kathleen. Michael,
so what I'd like to do, is in the interest of time, let's go to Michael, and then let's take that point to come back at the end of these 5, I guess, repost that question on how we would like to go forwards with using the consumer journeys. So, Michael?
Thank you. I suppose, and thank you. I think, look, these make perfect sense. I think where we're getting caught up, and this is where we probably need the point of clarification, is the patient summary something that is being curated by a clinician, or is the patient summary where information that is collected from different occasions of service, different journeys? It might be, you know, this example here, the GP visit interstate contributes to the patient summary. It may or may not change the patient summary, because it gets back then who owns the curation of the summary, all right? Or, you know, it's a bit like my health record, all right? The information is contributed to that and people look at it and you make the decision as a clinician, all right? As opposed to, I think we're talking about a concept around I write a patient summary, which in an acute care setting may be a discharge summary, all right? In different, you know, it might be a referral in another setting, etc. And I think this is where we've got we need a conceptual clarification around what that means, because, you know, if we're contributing data to that, it might be a data element, all right, as opposed to curating a new patient summary, and who is accountable for then managing that new patient summary. Because and you know, I've been doing a lot of work with Malaysia recently. They actually, for each patient summary, which may not be perfect, but they use it and it works well about their international patient summary. If you've got multiple, you have multiple QR codes and you share the multiple QR codes. All right. So there's not one, you know, go back to what was said before, there isn't one patient summary to rule them all. So just something that we might need to tease out, because I think we're getting caught in that around what the output is. The journey makes sense, the contribution points make sense, but you know, this is where now that's been brought out in some good questioning. I think that's the issue we're in.
I think that's
think
a
we have
great
a couple
point.
of-
Sorry, I was just going to say, I think that's a great point, Michael. I think we're
Thank you.
trying to. I wish I hadn't said that now. I think that's a great point, Michael. I think this is about an experience, and this is probably what I was trying to clarify to David's question in the chat. Not everything is about the data set. What we're talking about here actually isn't about the data set. It's an experience or workflow where people cross over, and that doesn't necessarily have anything to do with different clinical systems writing or updating or different data mixing. A common data set is one component. What we are talking about here and what the clinicians are trying to articulate is the actual user experience or workflow, the clinician's experience in a pathway. Now, that may have very different ramifications in terms of how the data interacts. And what I mean by that, not to overcomplicate it, is when we start getting into the finer technical pieces, this bit matters in terms of how those data sets, like I might create it and then another person has a component that they want to add. That update is different depending on whether or not they're at the clinic versus at a different clinic. Like there's different technical parts to that use case. These are very important to overlay, but right now they're not about the data or defining a data set. They're about defining the clinical experience.
Yeah, absolutely, Danielle. And I think what I think we want, and this is probably the intent you wanted, Tor, was very much around the clinician still has to look at the information and make a decision. All right. It's not about, I go to the patient summary, that's going to tell me everything about you. I don't need to ask you anything else. No, that's not what we're doing. All right. So it's still about, you need to use your clinical knowledge to do that. And it might be from multiple sources. All right. And they may not be complete.
Yeah. And I think as we go through the other journey, some of those questions will come up again and again, because we revisited them ourselves in the clinical focus group quite a lot as each scenario was talked through. I might move on to the next one if that's okay. And again, like keeping in mind that those similar themes do kind of come up across each consumer journey map. I'll talk through this one again, and then we can sort of pause for further questions. So this consumer journey is an emergency hospital attendance example, and this one was developed and aligns quite closely with the second technical use case, where it's the clinician-driven patient summary. So in this scenario, our patient is Charlotte Morris. She's a 30-year-old female. Charlotte is being taken to hospital via ambulance following a car accident. Presenting with various injuries, Charlotte is stable but unconscious. The ambulance staff access Charlotte's patient summary and note that she has an allergy to opioids. During the handover in ED, the ED multidisciplinary team are advised of the opioid allergy and are able to request the patient summary from Charlotte's usual GP. The system retrieves the patient summary, and then Dr. Hickson and the ED multidisciplinary team review the patient summary to see information on allergies, pregnancy status, vaccination status, other healthcare information. This allows Dr. Hickson to treat the accident-related injuries while minimising the risk of complications from underlying health issues, such as the opioid allergy. So again, this is a scenario where the patient is unable to provide a QR code necessarily to their patient summary. So the clinicians in the ambulance and also in the ED have requested a patient summary.
In the interest of time, I mean, if people need to ask questions here as we go through, we'll get them to put their hand up, and I think we'll go through each of them, noting that we are going to stop and have a discussion at the end. And we want to provide a link there so that people can put in the detailed I guess the list of questions that are really coming up on the overall theme to feed into the clinical focus group and to have our discussion is we're going to capture those on Confluence as well. So let's keep going, but at any point in time, to the people on the call, you can put your hand up and ask a question. Otherwise, we'll then take a pause at the end of these 5 scenarios and start the discussion there.
Yeah, sounds good. All right, we'll move on to the next consumer journey then. So this consumer journey is a referral where it's a referral to a specialist or an allied health professional. So this one was developed in alignment with the third technical use case where the patient summary is provided as a supplementary item to a referral in this example. The complicating factor that the clinical focus group have added into this consumer journey versus the technical use case storyboard is that it's actually 2 referrals occurring at the same time. And the reason for that is I think the group wanted to sort of highlight that it is a quite common scenario that you might see a healthcare provider writing multiple referral letters to for the same patient to different healthcare providers. So hopefully that makes sense, and I'll step through the scenario now. So in this consumer journey, our patient is Joyce Johnson. She's a 39-year-old female. So Dr. Burrows shares care of Joyce, who is pregnant and has recently been diagnosed with gestational diabetes. Dr. Burrows decides to refer Joyce to an endocrinologist and a dietitian for further evaluation and support. Each healthcare provider receives a referral which contains a link to the patient summary. The practice nurse at the endocrinologist's office or the dietitian open their referral and retrieve the patient summary. Using the information in the e-referral and the current patient summary from Dr. Burrows, each healthcare provider then triages their referral. The patient, Joyce, goes to see the endocrinologist first. During the consultation, the endocrinologist clicks the link embedded in their referral to view the current patient summary, including current medications, relevant medical history, etc. And then during the consultation, the endocrinologist decides to increase Joyce's insulin dose. The endocrinologist then writes a letter to update Joyce's usual GP and her midwife, as well as updating the patient summary to include the increase to her insulin dose. Joyce subsequently goes to her dietitian appointment, and during the consultation, the dietitian clicks the link embedded in their referral to view the patient summary. This updated patient summary now includes the increased insulin dosage. And same as the endocrinologist, the dietitian then writes a letter after the consultation to update Joyce's usual care team, as in her GP and her midwife, and updates the patient summary. So that sort of covers off that scenario. We'll move on to the next one, which is hospital to aged care interstate transfer. And I think, again, noting this was the additional scenario that was added that didn't specifically align to a technical use case, but it is essentially where the patient summary is a supplementary item again. And this was requested by the clinical focus group in order to highlight a more complicated but common scenario for our elderly patients. So in this scenario, our patient is Eleanor Nielsen. She is an 89-year-old female, and Eleanor is preparing for discharge from a hospital following a hip fracture. She's no longer able to live in her own home in New South Wales, and Eleanor will be going to an aged care facility in Canberra, close to where her daughter lives. The hospital staff update Eleanor's patient summary and discharge information, which will be sent to her new aged care facility. Eleanor arrives at her new aged care facility greeted by the staff who have her relevant information on hand. The aged care pharmacist reviews and reconciles Eleanor's current medications. Eleanor and her daughter then meet with the new GP. During the consultation with Eleanor and her daughter, Eleanor's new GP requests the patient summary from her previous GP. They review the hospital discharge summary, the patient summary from the previous GP to reconcile her medications, care requirements, confirming her patient summary information is correct and up to date. Eleanor's age is wrong. Oh, sorry. We'll update that. And then lastly, Eleanor's updated patient information is available to the healthcare providers in her new local area, including her new pharmacy when dispensing her medication. So that is that journey. I also do want to note, sorry, just popping back to that journey previously, for this item, we haven't specifically or explicitly called out that this is actually a transfer of her whole healthcare record as well. And so I just want to note to this group that we are aware that it probably does need some clarification around that point. So yeah, just as an FYI. So moving on to the next journey, this is the preoperative surgical scenario. This one was added by the clinical focus group to try and help highlight the consumer journey where there may be a delay between the initial referral for treatment or appointment and when the patient is actually seen, where the patient summary and where the patient summary may be used in that workflow. So in this scenario, the patient is Tristan Thompson. He is a 74-year-old male, hopefully that's correct. And Tristan has been experiencing gradually worsening vision, particularly with trouble reading and seeing clearly at night. After assessing Tristan, the optometrist suspects cataracts and decides to refer to an ophthalmologist for further evaluation. So the ophthalmologist receives the referral, which contains a link to the snapshot patient summary at the time of the referral, and the ophthalmologist requests an up-to-date patient summary from the GP. The ophthalmologist then performs a comprehensive eye assessment and determines a diagnosis of cataracts. After discussing the options, the ophthalmologist schedules Tristan for a pre-op assessment with a nurse to ensure that Tristan is ready for surgery. Tristan's initial preoperative assessment is delayed and is rescheduled to a later date. In the meantime, Tristan has to be started on anticoagulants due to a diagnosis of arrhythmia. The preoperative team then accesses the Tristan snapshot patient summary that was created at the time of referral and the current updated patient summary. From the current patient summary, the team identify that Tristan has now been started on an anticoagulant medication. And the preoperative team prioritizes and schedules a telehealth call with Tristan to confirm the details that have changed and to advise Tristan to cease his anticoagulants 48 hours prior to surgery. A surgical date is then set for removal of cataracts. So that's the last scenario. If we want to move on to the discussion of the Menti now, Danielle.
Yeah, so we have a couple of Menti questions overall before I think we go into discussion, but we can do discussion first. What I might do is actually, if I ask everyone to go to menti.com and use that code, hopefully you will see when I hit present, this question. And I guess that's that overall validation. Is that right, Toron?
Yes, yeah. So basically we're wanting to understand from this group, do these consumer journeys enable you to facilitate your technical discussions and your technical use cases? Do these sort of fit with what's required?
Also, I think we fixed the problem where we would only allow you to select one. So let me know if that's true. You're actually allowed to select multiple. It does look like it from the numbers.
Awesome.
Yes, it does.
That's great.
These are looking like a meaningful set, actually, looking at how many are coming through as saying this is actually fitting their use case.
Awesome.
Okay, so 25 people have responded so far. We've got a lot more people on the line, so I do want to keep this up and open. If you haven't used Menti before, either on your phone or on your computer, if you can go to menti.com and there you'll see the code, or you'll see a enter code field. And so you want to enter in that 8830 2879 at the screen. And that will then bring this up for you. I'll just put that in. I'll see that Richard has put a link in the chat. Richard, you had your hand up?
I just wanted to call your attention to the fact that what you've just noted.
Yep. So Richard's got a link there. So if you selected that, that will take you through. All right. I think we've got 30 people. Is there anyone else who's trying to vote, but it's just not working for them? Keith, you're on mute.
I just wanted to make a comment while people are voting still, very quickly. I mean, it's translatable, but the interstate GP visit, I don't know that it just needs to be interstate. I think someone who's a bit of a roamer would probably benefit from that kind of scenario as well. So it's pretty much the same thing, but you might have a usual GP but can't get to that GP because it's too long a wait, but you need an emergency GP to. So I think that's
Yeah, absolutely.
One of the first one.
Yeah, I think when we were discussing it in the clinical focus group, that did come up. Sometimes it's just, between towns because you're an hour away from home or something like that, or for whatever reason you're going to a different GP. That was one of the points that did get raised. I think we chose to call it interstate GP to try and highlight that it's a change of location scenario. But again, if it makes sense to make it a little bit more generic, change of location or something like that, yeah, please submit that feedback and then we can discuss it with the clinical focus group as well.
It really fits into the practice to practice that we've always talked about. But again, even using practice to practice terminology, people immediately make assumptions that we're talking about GP to GP, and it may not be. It may be GP to nurse practitioner, or there's a couple of different use cases there, right? So
yeah,
it really is. It's from one clinician to a clinician at another site.
Yeah, but not necessarily a transfer. It's still just a once-off kind of scenario.
Yeah, it's not a transfer, it's a view. So when I talk about practice to practice, I want to be able to see some information about a patient that is in another clinician's database.
Yep.
Yep. This highlights the fact that you don't have another way of getting at the data. So within the Northern Territory, a lot of the GP clinics will have access to shared information because of a territory-wide system. And so I think this emphasises the fact that you don't expect to find any governmental or organisational pathways to share the information other than what's in this thing we're talking about.
Okay, so what we're going to do is move on to the next vote. Now, we haven't had anyone else adding to this in the last minute, so we're going to note, I guess we'll note this. So it's good to see that nobody has said that none of these cases were a good fit. So that's great. So I think that means really that we've essentially validated that what the clinical focus group is coming up with is actually really meaningful for us to go ahead and use. And it's looking like all of these are actually really quite useful, but the referral to specialist and allied health has clearly got the most votes. What we'll do is actually then frame it this way. So yes, all of those are relevant, all of those fit. We can't and don't have time to go through and actually pick every single one of these and detail workshop them and go through those in R1. So what we're asking this group is, out of this set, can you rank these as what you think are the most useful for us to focus on in this first release? What's the key aspects? What are the foundational things? What should we really be targeting in R1? Now, this will be a little bit different for people if you haven't seen ranking. What will be shown now on your screen when you enter is that there will be a box at the top, which is asking you to drag and drop from that set of content. As you drag them up, and you can move them up or down, you'll then need to click submit right down the bottom again to have your results go back in. And if it's not working, just pop your hand up or just ask a question, and we'll see if we can work out what's going on and how to help. Really interesting. That's probably not what I expected at this point. Kathleen.
Yeah, Danielle, I think all the scenarios are fantastic, and I don't really want to rank them, to be honest. But the thing that I'm thinking isn't it just the overarching, as you say, practitioner to practitioner, or some sort of clinical person to another clinical person, regardless of whether they're an allied health specialist, regardless whether they're aged care, all that's sort of, this just supports the scenarios rather than how to do it.
You're right. No, you are right. So the technical use cases, as we said, as you pointed out, can be applied across like all of these. And I think when we go through and workshop these and look at these in real detail and try to share test data, we want this to be in the context of a consumer journey. And so we want to select some of the most meaningful consumer journeys across the set of participants in R1 to provide that focus as we go through and do the workshopping and try to create the test data and go through and start to test things.
Yeah, and I think there is the aspect of, obviously the technical use cases are considering it from a generic clinician to another clinician. But I think what the consumer journeys are trying to do is to help articulate specific clinical scenarios where the patient summary may be used in those interactions, and then what technical scenario would be applied, how it would work. So they're kind of more to help frame some of the conversations around how the generic technical use case might be used or implemented. So they're supplementary to the technical use cases, if that makes sense.
But can I just make one suggestion? A hospital to an aged care transfer, regardless whether it's interstate or just down the road, should always have a summary document going with it, regardless of what's going on right now. So I think if we might need to look at this slightly different, is where is it not done very well right now if we're going to concentrate on some scenarios and choose one to go over the other. So the hospital to aged care transfer is absolutely required, but it happens now. And if it's not, that's not because there isn't a patient summary, that's just because of poor care and poor handover, but it should be happening right now. So I'm just saying that that's probably not as high a priority in my head because it's already has some processes around it and happening. So therefore I would be inclined to look at something different. But anyway.
Absolutely. And that, I guess that's what we're sort of asking you now. So we've created these journeys to illustrate where the different summary interactions occur. But yeah, I think it's totally up to this group in terms of what needs to be prioritized for the patient summary project team to focus on.
And Vince?
Thanks, Danielle. I want to make sure that everyone is aware that there is already an aged care transfer summary document, which is a requirement for aged care to hospital transfer that was put in place last year. So many of the systems have already implemented that. So I'm not sure if you're intending to duplicate that capability. It doesn't seem like a priority to me, given that we already have that requirement in place.
Thanks, Vince. Richard? As last comment, I think before we move to come back and discuss.
How is the hospital to aged care interstate transfer different to a discharge summary?
I think that might be more specific questions you might want to add on the consumer
Can I take
journey.
this?
Absolutely, please do.
It depends on whether you talk about now or the view of the future, Richard. So the view is that in the first instance of a practitioner to practitioner handover of any information, that's not necessarily a transfer of patient, but if I'm sending information to another practitioner about a patient because they're new or they haven't seen anything about them, the current view or approach is that that is a patient summary, whether that is GP to GP, GP to aged care to hospital, hospital to GP, hospital to allied. The first thing you would send is a patient summary that gives a summary or snapshot about that patient in time and then allows the clinician on the other end to go, if I want more, query for more information. So whilst that's not how it works today, the view at the moment, or the current working approach to how we do patient summary, is any transfer of care starts with a patient summary as a basis.
Right, thank you.
Okay, thanks everyone. So let's come back now. We've gone through that. We have those results that have been submitted on the series of preferences between emergency hospital attendance, interstate GP visit, referral to specialist, and allied health. And so that will come into the scoping workshop as I think the foci, as well as some feedback back to the clinical focus group. Let me get back to the slide I'm meant to be presenting. Sorry, where is that? Here. Okay. So if you can walk that through, Tor, on how people can provide that feedback.
Yeah, absolutely. So we have posted each of these consumer journeys on the Confluence page that's linked there with those same prompting questions that we had posed at the start before running through the journeys. So what we'd like to ask from this group is that if you do have any comments or feedback in regards to the journeys, please go onto the Confluence page and add in your comments, your feedback around the journeys. You can provide overall feedback as well, and then any specific changes or requirements that you'd like to see. I will just like to call out that the feedback will be taken to the next clinical focus group. So we are asking that if you could provide that by the 5th of December, which is next Thursday, as our next meeting, and our last meeting for the year is on the 6th. So ideally, we'd like to be able to discuss the feedback there. And also just calling out as well that not like all the feedback will be considered, but it doesn't necessarily mean that it will be incorporated into the journey maps, as they are will be discussed more broadly with the clinical focus group and with the CDG as well. So just want to note that there. We will do our best from the clinical focus group on the 6th to then update the consumer journey maps to have at least an updated draft version that you can then use as a tool in your patient summary workshops on the 11th.
Thank you, and I hope the updated content will also then be updated on the Confluence page when we have that available, and I think we might even send out notification to people to let them know if there have been any changes before we come back in a virtual call in January, and keep talking about it.
Yeah, absolutely. So sorry, Danielle, you've got your hand up. Was that an old question, old hand? Danielle B?
I was going to potentially answer the bit of the commentary and the thing, but then I started typing and now I'm halfway into the novel.
Okay.
Maybe we just cover this up top, because I think it was something that was missed that we talked about last time. There's been some conjecture around, this sounds like multiple clinical summaries. Have we not solved one clinical summary to solve them all? I just want to be very clear, both need to exist. So there is absolutely a use case that is not being discussed here, is not in phase 1, because there is no infrastructure in place to support it today. And there is a considerable amount of work that needs to be done by the government to support it. And that is the example of, I am in a centralized national system like My Health Record, and I want to be able to view a patient's patient summary through that, where I can potentially look up and say, give me a patient summary for this patient. And that will go and find all the data in any source system that has that patient. For example, through the HIE, go to multiple clinical systems and construct a patient summary on the fly that says this is a patient summary, including data from the My Health Record. That is absolutely a use case, but there are a number of things that don't support that today, like a record locator, connections to a HIE. So we've been asked to put that in a phase 2 later, when the agency and the department have made more advancements in that area and considered some of the architecture with that that's already working in the background. There is still a use case, irrespective of that, where being able to provide a real-time, meaningful patient summary from a source system is required in a clinician-to-clinician scenario, and that's what we're talking about today. So the purpose of this first release is to support what can be built and prototyped and put in as an actual working proof of concept between industry of being able to actually supply real-time data as a patient summary in these scenarios within the next 12 months. So what we're talking about today will actively be a system-to-system example being shown next year. And the really simple one that we're talking about, for example, is where a clinician needs to provide a patient summary to another clinician who has never seen that patient before. I need to be able to generate a patient summary in real time that can then be presented to that other clinician to give a context and summary information at the start to give them a background to that patient. So I hope that makes sense. There are two different ones. We're not trying to dismiss that there is the My Health Record part. That's definitely part of our thinking and approach. Any patient summary created by a source system is also intended to be uploaded to the My Health Record to be viewable and accessible as well. So I just wanted to clear that up.
Thanks, Danielle. And we can have, I think, some of that conversation and some of the other perspectives as well in the technical use case portion of this meeting, which won't be as long as this one, which is fine. It is really important we have that walkthrough on the consumer content. Tor, did you want me to move to the next slide?
Yeah. So we'll go over this quite quickly. Obviously, we've taken up quite a lot of your meeting time. So just wanted to give an update, obviously, on AUCDI R2, which is the patient summary component. So noting that for AUCDI R2, we have broken it up into 2 releases to provide public comment. So the release in regards to patient summary data is now open for public comment, including by anyone in this group. So what you can see on the slide in front of you today is those data groups that have been prioritised by the CDG for inclusion in patient summary. So I just want to note, obviously, that just because it's been prioritised by the CDG, it doesn't mean that there's a specific technical requirement for implementation. That's obviously up to this group to work through. And I think it's just considering what can be done now and what can or should be moved to R2 or a future release for patient summary, and any other technical considerations that the group here can solve. So thanks, Danielle. So in order to provide feedback, an email was sent out into all Sparked community members. So hopefully most of you will have seen that come through yesterday. And so information on AUCDI R2 is available on the Sparked website, and you can provide feedback via a Microsoft form. We're looking for general feedback on this patient summary component of AUCDI R2, specific feedback around each data group and data element, and then an overall recommendation for each data group. And the closing date for that feedback is the 17th of Jan. So if there is some reason that you do need additional time, please feel free to reach out. You can email us at sparked@csiro.au, or if you do have any questions, please feel free to reach out. And I guess just noting, obviously, that this is something that will be probably more will be used to help develop the roadmap for implementation of patient summary, working through what items will or won't be included. So that's all from me. Thanks very much.
Thanks, Tor. Really appreciate it. We look forward to you coming back in our first meeting in 2025 and telling us about it all over again on what's been updated.
Can't wait.
Thank you. Next portion of the meeting then is to look back at the technical use cases and also look at the FHIR IG project as a whole, including some of the timeframes. And I'll pass over to you, Heath. Did you want to share your screen?
Yeah, I'll do
right.
that. Okay, I think that's my screen now.
It is.
Okay. So just to reiterate some of the expectations, I guess, as being a member of this project group within the AU Core TDG, that we are going to have fortnightly online meetings. We're likely to have quarterly, we're going to have quarterly face-to-face meetings, and we're going to have quarterly connectathons to try and test the profiles that we're actually generating. So this is, I guess, our expectations of you being a member of this project team is to have this kind of regularity of meetings so that we can progress this work. Once we get a working draft of the IG, we will be taking this out to vendors for testing and validation that the IG is workable. And that is likely to start in around April next year. And then we'll get into ballot activities for basically we're looking at 2 steps, one for comment in August and then a subsequent ballot activity in 2026 at the beginning of that year. So just pictorially, this is what it looks like. There are obviously some or potentially some dependencies that we are looking at aligning the patient summary work with what we've already done with AU Core, but there may be some additional requirements that patient summary requires. And as you've just seen from Tor's presentation, there is some work around the pregnancy items, for example, that are in the scope of the AUCDI for patient summary that we'll potentially need to address. So we're going to meet, I guess, in next month in December. We're going to have our 1-day workshop around scoping out what is in patient summary, and the following day we're going to have an AU Core scoping session, and the items that we've identified from the previous day will be brought to the attention of AU Core from there. So it's a very important meeting coming up in December. So you can see those meetings that we've got, and then we're looking at a potentially a meeting in early January, but I think we're going to have a vote on that later on when our next meeting is going to be. I think we presented this slide, I think, last time. So just to basically, we are at the very, very beginning of this particular project where we are really just starting. We've gone past the proposal level, and we are going to start producing the initial content, and hence we're going to be basing that on the use cases, obviously coming from the AUCDI, turning those into technical ones, and then we're going to start working out, okay, what are the workflows? And I think from my perspective, the last discussion we were talking a lot about what's the data, what's the difference between different use cases, and etc. But what we're looking at with those technical use cases is what are the workflows, the actual interactions between systems. That for me, that's the key of those use cases, is to work out what are those interaction patterns that we have to support those particular patient journeys. And that's the difference for me between those journeys. Okay, so let's have a look at now how those technical use cases appear, and the use cases that we've identified. So we're in this kind of iterative loop. We identified some technical use cases. They've gone back to the AUCDI. They've worked out their clinical patient journeys. So it's great that now we've got some clinically driven scenarios to drive some real scenarios that are useful, things like aged care, etc., and emergencies, and that we're able to actually put these technical use cases more in context. And that's really how we're going to also present these technical use cases, very generically, so that we look at what are the common patterns, as I was talking about, but also how they fit into to solve the problem of those particular journeys from a clinical perspective. So we will come back to the part on the right in a moment, but I just wanted to very briefly go through these because it's probably getting a little bit repetitive, and we're short on time. But keeping in mind what we've really extracted out here is that there is a use case around a patient-driven patient summary. So on the right-hand side, it's kind of a different representation to the journey slide that we've been presented, but pretty much it is an example of that particular journey of that interstate travel scenario. But from a technical perspective, we're talking about a patient providing a unique link that identifies a patient summary in the source system. So being quite abstract around what is the source system. It could be the My Health record, it could be something else, a GP system. The patient can use this to access the summary themselves or provide to a third party to access that patient summary. Now, we've used the term unique link, not a QR code or anything like that, because in the end it's abstract. So somehow we're representing that unique link. So it is a unique link to a specific patient summary. The next one is the technical use case 2, which is a clinician-driven patient summary. So I like to sort of describe this more as something that is being discovered. The words that are being used here at the moment is, again, a unique link that identifies a patient summary in a source system when requested by another clinician. But somehow we've got to be able to discover that unique link. So, for example, a patient presents to a healthcare service for an unplanned visit, and the clinician asks patient summary discovery if any summaries exist for that patient, or the patient's regular doctor details are used to request the latest summary from that source system. So that correlates to or supports that second consumer journey scenario. Somehow the ambulance has got to try and find that patient summary. The patient is actually unconscious, so they can't hand over the QR code, so it's got to be discovered. And similarly, there's probably some break the glass sort of scenarios and all those sorts of things, but ultimately we've got to find that, and we've discussed that abstractly on the left-hand side. And finally, it is really the referral scenario where it is coming across as the supplementary information or supporting information as part of a referral. So the patient or the practitioner who is actually creating the referral is also the custodian of the patient summary and just wants to attach it to that so that it can be retrieved at the time of triaging the referral when it's been received. Again, this is a unique link to the specific summary that was provided as part of doing the referral. So it could be a curated summary in this particular case that is relevant for that particular referral. And of course, we've got all those fourth and fifth patient journeys, which appear to me to be very similar in nature to this as supplementary information. Okay, so you do want to go to the Minty on this one, Danielle. I'll transition back to you.
I think we have time. If people, yes, want to go to that, I think if people go to the Menti now, you can see the similar question really that is being asked on the technical use case as it was for the, and I should probably share my screen actually. Replace current share. There we go.
Yeah. So any questions while Danielle's setting that up along the way? I'm sorry I'm going through it so quickly, but I think it is getting a little bit repetitive. You have seen it before. It was really a review for those. So looks like we're straight into the Minty, which is great.
Okay, so that's 21 people on call who have submitted. And I think that this is echoing the discussions we had around the consumer journey about the ability for either the patient or the clinician to provide the access. That's looking basically reflective of that, I think.
And I guess there's something else in particular here is if there is, you think there is a technical use case that, well, if there's a clinical journey that is not represented by these technical use cases. Okay.
All right, so we've got 33 people now who've responded, which is what we had from our previous one. So I think that, 34, extra one, awesome. So I think we can take those numbers as providing validation that that set of use cases, looking at patient-driven, looking at the clinician-driven around that, the granting access is actually a meaningful set. So I think you could take this on now, Heath, and move to, I think, a motion.
Okay, so you skip the discussion.
No, sorry, apologies. I think you have a remit for us to motion on agreement to accept that these are a meaningful set of use cases for us to take forwards. And I will stop sharing and let you go from there. Oh, we've got 37. So we'll just give it another maybe 20 seconds to see if we get anybody else who's adding to that. And no, so we've got 37 responses, which are what we saw just before.
Okay, so I guess if anyone wants to have a little bit of discussion, think about how you're going to present, how you're intending to implement patient summary. Would like to share your thoughts around this, and I noticed that there is someone that mentioned something else here. So perhaps if that person would like to share their rationale on that one, as an opener, you don't have to, but if you would like to, that would be interesting. So, but if there's any other vendors out there that would like to share any of these sorts of points, that would be helpful, and then we will move forward. No? Okay. In that case, we would like to basically get a motion on this, that these three technical use cases will be included as the scope of patient summary release 1.
I'm happy to move that, Marika.
Hi, Marika.
Thanks, Marika. So you've motioned. Is anyone happy to second that?
Marvin here. I'm happy to second it.
Thanks, Marvin. So I'm going to launch the electronic poll. So the current motion is that we accept that these use cases are what we're going to take forwards in the scope to work on for AU Patient Summary Release 1. Okay, we've got responses coming in thick and fast. I think there's about 50% of people have responded so far. Okay. And now we've got 70% of people have responded. So I'm just going to leave that open for a little bit. People are still coming in and voting on whether to accept that we will go forwards with those three that we just walked through earlier. And I'm going to count that off in 5, 4, 3, 2, 1. And I'll end that poll and share the results. So what we've got is that there are actually, let me check the chat just in case anybody put in a chat motion, which I can't see. If you did put in a chat motion, just sing out.
I don't see one.
Okay, great. So that's 40 people have responded with affirmative, 0 negative, and 2 abstains. That motion passes. So we're going to take those forward as the base set of cases to be working on in R1 of patient summary. Thank you.
And I guess just to note also, if you do have some commentary on this, although we've motioned the technical use cases, if you've still got feedback around ambiguity in the wording, names, those sorts of things, please put your comments at the bottom of this page. Okay, so we just want to, with the 10 minutes before leaving 5 at the end, we want to just perhaps revisit some of our assumptions that we've made and validate those assumptions, in particular around the standards that we're going to base our AU patient summary implementation guide. And effectively what we're proposing here is that we want our Australian patient summary to be compliant with IPS, the International Patient Summary, but using content based on AU Core, so that we're able to leverage the reuse of our AU Core implementations as part of our Australian patient summary, but at the same time making it internationally relevant and shareable. We're also looking to create a new IG, and that will include a series of profiles, including an Australian patient summary document bundle, through to a composition and the various other profiles that we require that enable the AU Core resources that we already have to be compliant with IPS. And there's various forms of how we actually do that we'll discuss further, but these are really the principles that we're trying to get agreement on today, that's what we're trying to do. Access is also key to this.
So Heath, we've got a bit of a time warning at this point.
Okay.
We need to move on.
So access is key to this as well. So we're looking for a motion that basically just simply agrees that we are going to base our Australian patient summary on the International Patient Summary IPS release. I don't know why release 2 is in there. It is 2.0.0. It is actually an STU for trial use, standard for trial use, version 2, not an R2. We're also going to base our content on AU Core release 2. So notice that we're skipping release 1 at this point, because we will need additional requirements coming from AUCDI. And of course, the underlying basis is that it is based on FHIR release 4. So I've got some comments, questions from Andy.
There is no direct use of AU base you think would be needed?
AU base comes in through AU Core, but it is a very good point. We can edit that and list that it should be the latest version of AU base that is tied to that version of AU Core. We make that amendment, Heath, to be very clear.
So just basically AU Core R2 and AU base version, whatever it's going to be.
It'll be R5, I believe.
Okay.
Which is, so these, I guess this is the motion form of what we discussed last week and putting that into an actual decision. But yep, that's a good one. And sorry, Richard?
Based on, hopefully that's a little vague so that we can be aligned with, derive from, or whatever appropriate implementation approach we choose.
It's dependency, that's what's listed. It would be a dependency. Whether it's derived from or not, I think the motion is that
it's based on. Yeah.
Yep. Okay. Thank you. Good.
So whether it's actually explicitly
no. There's a range of ways
with,
and there's a range of ways of ensuring the alignment. I'm just hoping that it's vague enough that we can choose the most appropriate one for the different parts. Thank you.
And I'd expect that we're going to have a look at some of those things next in a fortnight's time. Okay, so
we have
I'll
one
put the
friendly
motion
amendment. Okay.
With the friendly amendment of AU base release 5, which is the future one, not the one that's just been balloted.
Okay,
I'll second, Marika.
Thank you, Marika. So we have a motioner and a seconder for that. I will bring up the poll now unless there are any other questions or discussions. I will relaunch that poll. There we are. So we now have a poll up for the current motion with the friendly amendment to include AU base. Okay, 50% of people have replied. All right, we've now got 70% of people who have submitted a response. And I'm going to count that down from 5, 4, 3, 2, 1. And I will end that poll and share the results. So let me just check the chat. Doesn't look like anything's in there. So for the current motion, we have 35 have voted affirmative, 0 negative, and 6 abstain. So that motion carries. We accept those as the target dependencies for the AU Patient Summary R1. Thank you, everyone. I see you've stopped sharing, Heath. Is this a Danielle, please take over?
Yes, it is.
Oh, okay.
What's next, Danielle?
Okay, this is a very good question. Let me share my screen. Okay, can everybody see that?
Yep.
All right, let me pop that up. Okay, what's next? So just going back to these meetings, we're going to come back in. Wow, okay, I've got the dates wrong. That's really impressive. We're not time traveling. We're coming back in 2025. Not coming back in January 2024. Sorry about that. I'll fix that. And what I really wanted to do is check on our Friday morning times going forward. So this is a Menti again. I want people to go to the Menti, use your QR code here, and I'm just going to put up the preferred time question to confirm whether or not we're going to keep doing the times we have, or if people want to actually move this to be a little bit earlier or later. So again, it's a ranking because I know that more than one time might work for people. Heath, you've raised your hand.
I have. I'm just wanting to put on that it's every other week from the TDG rather than the same week. Is that something that we can suggest, or?
That's a separate.
Okay.
So there's not going to be really depends on every other week from which TDG. So at the moment, there are 5 calls that are being done through HL7 Australia, I think. There's the FHIR work group, there's the AU Core Technical Design group, there's this call, there's AUE requesting, and there's also a tooling community call that is undertaken. So there's no other week that is free of anything else. We'll either be the same week as e-requesting or the same week as AU Core. And if we move, we would be the same week, I think, as FHIR work group and e-requesting and the tooling call.
So I guess my rationale is that these are both TDG calls, and yeah, so just having those TDG members, I know that there are some members that are also in the requesting this, that doesn't help them, but at least for the majority of the TDG members, it might be help.
All right, so we'll go through this one and then we will look at your proposal and see if.
Sorry, I'd just like to mention also that the people on the West Coast should be considered as well, because once the clocks change and so on, it starts to get quite early for people, particularly if they've got family and they've got to take children to school and so on. The time that we have the meeting here on the East Coast could be at odds with that.
I agree. This will hold until, I would suggest, what we should do, and I think we would do anyway because it is just good practice, is when daylight savings changes, that we reconfirm the meeting times every time there's a shift in time zone. And yes, sorry for folks in 3 other states. I couldn't actually put all the text into the question, so I couldn't list every state. We've got responses from 25 people on the preference, which is at the moment the current time we've been meeting. I'm just going to give that another 30 seconds. For anybody else to chime in if you want to, in terms of putting the preferred times. All right. So looking at that, the time that is being essentially reaffirmed is 10 a.m. I think we should have a motion on that to confirm that. Is anyone happy to motion that we keep the current meeting time for Friday mornings in 2025?
Yeah, I'll move that.
Sorry, Kathleen?
Kathleen, I'll move that. Yeah.
Thank you, Kathleen. Is anyone happy to second that?
I'll second it, Michael.
All right, I'll pop that poll up. So relaunch the poll. So this poll is to accept the current meeting time starting within 2025. It does not mean we cannot change this. It just means that I'll be able to send you meeting series for 2025. Okay, we've had about 55% of people vote. So we're just having that coming through now, up to 70%. And so I'm going to count down from 5, 4, 3, 2, 1. I'll end that poll and share the results. So at this point, we do have 30 people have voted affirmative, 5 negative, and 3 have abstained. So for now, we will start in 2025 back at this time. I'll stop sharing that. Heath, did you want to raise a motion to change I guess the off week, if you will, or what we are the off week from? If I show the calendar now, and I just zoom in on that a bit. Sorry, I realize we're getting close to time, but right now, there's firework group, e-requesting, and then infrastructure call in that week. And in the other week, there's AUCDI and patient summary. So if we were to move patient summary, it would be firework group, e-requesting, infrastructure, and patient summary would all be in the same week. And AU call would be on this Thursday.
Can I try it another way and say that I propose that we start on the 20th of January or potentially the 6th if we really are keen, more so than that it's an off week.
So that when AU core is coming back is the 23rd?
Correct. So I'm suggesting that maybe, why am I looking at something weird?
I don't know.
I'm looking at December still.
Okay.
Yes, so starting on the 17th.
Which will put us in the same week as the firework group, e-requesting, and infrastructure call.
Are you suggesting that there be no meeting on the 10th?
Yes.
That's a different thing.
That's to basically get us into the off week. So I'm trying to kill 2 birds with 1 stone.
Yeah, and I just want to caution for people who are on other projects. This week here, we'll have the firework group here. And there will be maybe e-requesting there. Like we ask if we move patient summary to that week, it is stacking a lot of meetings into that week.
Yeah.
Continuing on fortnightly. That's what's being proposed. And it will conflict with the current infrastructure and tooling timeframe. We will run into that.
Okay, so
I mean, we can propose it and we will just be running, HL7 will be running 2 calls at the same time. So yeah, if you want to motion that, you can, that we move to the week that puts us in with infrastructure tooling, e-requesting, and the firework group instead of this week.
So can we do a vote with a affirmative is the 17th, and a negative is a 10th.
Or 24th. Yes, it's the,
I mean,
Trish,
there
what
is
you're
an
talking
option.
about is off week. Yep,
There
sorry.
is an option to just not have the meeting on the 10th. If there's belief is that there will be there'll be a lack of important attendees on the 10th, then there could be a motion just to say, well, we don't meet on the 10th. It's a bad week. It's caught up in Christmas. And without actually rescheduling the one from the 10th, just to say, we don't start having these meetings until the 24th.
Okay.
That would seem to be another option here.
Okay, so abstain is 24th.
Okay, I can actually craft a. Let's create a poll. Surveys. Create. Everyone gets to see me do this. Apologies if this gets a bit weird. Okay. I don't care. Skip to okay, so choice 1 is Jan 10. Choice 2 is January 17. And choice 3, which is Jan 24. I think that's together, 10, 17, 24, right? Essentially, that's what's being proposed. Is that acceptable? Shall we put up that poll?
Yep.
Yep.
Okay. Save. If this works, I could just launch that now. Let's have a go. I've never done this during a meeting before. Oh, it's acceptable. Okay, everyone should see that now. Oh, hang on, it says abstain. Sorry. I think I got that wrong. Hang on, let me go back and fix that. Close.
The dates are also
And
showing
23
strangely.
23 should be 24.
You
but I
were
guess we'll
you
understand it
displayed
as
the wrong
24.
vote. Displayed the wrong one. I thought
Back.
there was another meeting, another survey, the one above meeting start date.
Oh, that one. I launched the wrong one. Oh, well, that's fine then. Let's do that one. Why are there two with the same name? That's horrid. Okay.
TDG.
They have
all right,
different
meeting
dates.
Start date.
They've got different dates. One has 9 and 7. Not yeah.
All right, let's try the right one then. Okay, that should work. Can people see that?
Yep.
Yep.
All right, good. Okay, we've got 60% of people have voted on that. All right, so we've got 80%. I'm going to count down now. 5, 4, 3, 2, 1. All right, I'm going to end that poll. I'm going to share the results. So what that's showing is that 3 people voted for January 10. And I'm with you if I was allowed to vote. Let's come back then. But anyway, 7 voted for January 17 and 14 have voted for January 24. So January 24 is when we will come back and start the meetings for 2025. We can revisit this if the meeting series, both the dates and the times, turn out not to be working for this group as we go forwards. So I'll stop sharing. So that has finished. Okay, so we're over time, but I'm going to essentially just quickly wrap up at the end here to say we do have the scoping workshop coming up in Melbourne. There's a whole bunch of people coming, which is amazing. We're going to go through a lot of content, taking in the consumer journeys and the technical use cases to workshop those into things like our data scope, like which is the sections and so forth. If you'll get an agenda coming out to you, and also I'll try and be in touch to get a one-on-one before we do that. And otherwise, I will see you folks in either Melbourne or I'll see you folks in our call on, I think it's January 24, we decided. That'll be the next time. So thanks everyone for your participation today. I think we got to some good results.
Thank you.
Thanks all.
Thank you.
Yeah.
Thank you.